Assalamu alaikum student. We have already started abnormal labor in which we have already discussed about the dysfunctional uterine activity, its treatment. Then we discussed about the Cephalopelvic disproportion, the sign of Cephalopelvic disproportion and examinations, PV examinations and other and complications. And today we are going to discuss about a very another important topic which is for progress in second stage of labor. How we will identify that the progress is poor in the second stage of labor. How we are going to know that the progress is labor? If after 2 hours of pushing in nellipara and 1 hour of pushing in multipara, the delivery does not occur, then the delivery is said to be delayed or the progress is said to be poor. In second stage, if a woman do efforts for 2 hours, do pushing for 2 hours, and a multipara do efforts for 1 hour, and even after that if the delivery doesn't occur, then we say that the progress is poor in the second stage of labor. What is the most common cause of poor progress in the second stage of labor? The most common cause is secondary dysfunctional uterine activity, and it is exacerbated by epidural analgesia, because the epidural analgesia delay the pushing of mother, affect the pushing of mother. Now, if the cervix is fully dilated but the uterine contraction are poor or weak, then it result in maternal dehydration and ketosis. If the cervix is fully dilated but the uterine contraction are weak, it result in maternal dehydration and ketosis, and we will treat this condition by either rehydrating the woman or giving IV oxytocin. This IV oxytocin will increase the contraction of the uterus in primary para, but in multipara we don't have to give the oxytocin. We will assess the multipara for other conditions to exclude other diagnosis, because in multipara it is very unusual that the progress is due to dysfunctional, that the poor progress is due to dysfunctional uterine activity. So in multipara we exclude some other causes like malposition, malpresentation, and we assess the multipara for other causes. Now, what is the second cause of the poor progress in the second stage of labor? So the second cause will be related to the passage, the birth canal. It will be related to the passage, in which two are most common: narrow mid pelvis and resistant perineum. If the mid pelvis is narrow due to android type of pelvis, if a female had not normal gynecoid type of pelvis but had android type of pelvis, her pelvic cavity will be narrow, due to which internal rotation will not be occur, and head will not descend, and head will arrest at the level of ischial spine. Head will arrest at the level of ischial spine if the mid pelvis is narrow, and this arrest is called deep transverse arrest. Due to this deep transverse arrest, we will then do C-section. And if the perineum is very resistant in the nullipara, then it also result in deep transverse arrest, and the resistant perineum is an indication for episiotomy. Episiotomy is a deliberate surgical incision given to increase the vulvar outlet. So we will, in this case, we will do episiotomy to increase the vulvar outlet. Now there can be a problem in the passage which will lead to poor progress in the second stage of labor, and the problem in the passenger is we have discussed about the problem of the power, we have discussed about the pathology of the passage, and now we will discuss about the pathology of the passenger. So if the head is in the occipito-posterior position, that is if the head fail to rotate to the occipito-anterior position, or if the head takes a long time in the rotation to the occipito-anterior position, it can lead to delay in the second stage of labor, as well as if the head fail to rotate to the occipito-anterior position and remain there in the occipito-posterior position, and the delivery occur in this position. This delivery will take time. This will result in phased delivery. face to pubis, there will occipito-posterior position is basically face to pubis, in which the symphysis pubis and the face are in relation with each other. They lie against each other. So in this case, this will also result a poor progress in the second stage of labor. How we will treat this condition? We will either do instrumental delivery. If there is face presentation, we can do in instrumental delivery. If there is occipito-posterior position, we can do instrumental delivery, and we can do C-section if the safety criteria for instrumental delivery does not meet, and we can also do episiotomy if there is resistant perineum. This was all about the cephalopelvic disproportion. Thank you.